recording. So hi everyone, my name is Evelyn. I go by Eva. I'm a third year at ToroCom Harlem, and I am the committee chair of the New York Emergency Medicine Student Council. So a couple things to go over. We actually have also a pediatric emergency medicine panel we'll be having on March 24th. So look out for an email for that. And our year as a council is coming towards the end this month, so we'll be putting out an application for anyone who's interested. It's a great opportunity to network. Clearly, like we get to talk to really amazing people in the field. So we encourage people to apply who are from New York medical schools. So we can get started if we could just have people introduce themselves, what fellowship or what they're in, and where they are. So we could start with Dr. Mohan.
Yeah, sure. Hey guys, thanks for joining us. I'm currently a first-year medical toxicology fellow at NYU Bellevue. I grew up on Long Island, and I've kind of stuck with the NYU family for a long time. I've been there since I was a medical student, actually. So they keep on trying to kick me out, but I keep on staying in somehow.
Thank you. And then Dr. Halperin.
Hello, everybody. My name is Mike Halperin. I'm the Emergency Ultrasound Fellowship Director at Jacobi in North Central Bronx. I trained at Jacobi Montefiore, went up to Boston for fellowship at Mass General, then came back to the Bronx to, I guess the word we're using is reboot our fellowship.
Dr. Mann.
Yeah, hey guys, I'm Dr. Mann. I'm from Virginia and did my residency in Cincinnati, and then did fellowship in wilderness medicine with Dr. Halperin up at Mass Gen in Boston. And I'm currently the director of wilderness medicine in Greenville, South Carolina with the University of South Carolina, Greenville, and work search and rescue and a bunch of other things down here. So happy to answer questions about any of it.
And Dr. Surles.
I'm Taylor Surles. I'm the second year medical education fellow at Kings County and SUNY Downstate. I did residency at the same place, originally from Texas, but moved up here obviously for training. And so once I'm done in like 3 months, I'm going to stay on as faculty. So I can answer any questions about more in-depth education and things that are going on.
And Dr. Cardell.
Hi, I'm Annemarie Cardell. I am faculty at Maimonides Medical Center. I did a simulation fellowship there now 3 years ago. And now I'm staying on as simulation faculty, and I run our resident simulation education.
And for any of the attendees, we have the Q&A function. We'll be all able to see the questions if you are interested in submitting a question, and we'll try and get to it. And we also will be going through the questions that you guys submitted through the Google Doc. So just to get started, I think first we'd want to know, what is your area? Like, what is ultrasound? What is toxicology? So maybe if we could start with Dr. Halperin.
Sure. What is ultrasound? So ultrasound is a bedside tool that I think probably we all use in the emergency department, whether we're toxicologists or wilderness med or education folks. It's useful for pretty much every chief complaint: chest pain, abdominal pain, traumatic injuries, essentially bedside diagnostics, which in this day and age is pretty cool in that it's expanding beyond the bedside with a lot of the handheld companies that are getting into the market. So it's really exciting. It's good fun. Happy to try and answer any questions you guys have.
Okay, and then Dr. Cardell, simulation, what's involved with that?
So simulation as a specialty is basically playing pretend as a way to learn medicine. That's kind of how I think about it. Simulation can be the mannequin simulation that you do during your OSCEs. It can be standardized patients or actors. It can be a tabletop exercise where you go through the process of doing something, and it includes all of the procedural training that you do for chest tubes and intubation. I went into SIM because I think it's a very powerful tool for medical education. And because I wanted to learn specifically about debriefing, which is where you talk about an experience to try to gauge, to try to really pull the learning from it and help make those connections. And that's why I did SIM, is that was a skill I wanted to build. But it is used currently for a lot of resident education as a way to get some of your procedural training. And it is also has some really powerful tools in terms of patient safety work, using it to kind of help address patient safety incidents in real time with in situ type simulation.
Thank you. And Dr. Mohan?
Yeah, so medical toxicology very simply encompasses the study of poisoning or overdose, which is very generic because that kind of spans the whole spectrum from, quote unquote, street drugs, cocaine, heroin, ecstasy, all the way to pharmaceuticals, regular beta blockers and calcium channel blockers, to things that you wouldn't, quote unquote, normally ingest on a day-to-day basis, like the 2-year-old who accidentally, gets into grandmother's pills, or the patient who drinks, bleach or engine oil or kind of random things like that. So there's a lot of integrating with poison control centers and working on not only a patient level, but a public health level as well.
Thank you. And Dr. Mann, I actually saw Dr. Mann speak at a wilderness medicine conference a year and a half ago, and he spoke about space medicine. So he does wilderness medicine, but if you even want to add a little bit about space medicine, that'd be awesome. What is it?
Yeah, sure. So wilderness medicine is one of those kind of interesting niche-y subspecialties that you tend to find in emergency medicine. And much like emergency medicine, we can cover a whole breadth of topics, and you can really fit yourself into a variety of different niches in your career, depending on what you want to do with your life. But we essentially specialize in the mixture of the environment and the things that can happen to you in interaction with the environment and in an austere setting, and how we can adequately take care of you and prevent those types of injuries. So like Eva was saying, one of the things that we learn about, one of the things that's part of our fellowship is space medicine. So, we learn about the austere environments of space, how microgravity affects the body, and people can take that and move into a career into NASA and those types of things. Or you can sort of overlap with those other specialties, some of the things you've already heard tonight. We touch a little bit on toxicology, we do touch a little bit on ultrasound. So we kind of have this breadth of knowledge base that comes with wilderness medicine, but really anything that interacts with you and the environment is what we do. So a lot of us make our careers kind of working with snake bites or hyperthermia or hypothermia, making protocols for hospitals, working search and rescue, doing expedition trips or planning for teams that are going out into the wild. And so you can really kind of fit yourself in a whole variety of different ways in our field.
And Dr. Surles, how about medical education?
So mine may not be as flashy as wilderness medicine, but so the focus of medical education basically focuses on all aspects of education within the medical field, right? So we focus on how to better teach and how to better train residents, how to better teach and how to better train medical students, but then also how to better teach and better train other faculty going forward. Also developed within this, as opposed to just focusing on a single tool like SIM or like toxicology or something else. Kind of our focus is how to disseminate all that knowledge more efficiently and more effectively. Additionally, we teach things like leadership and kind of prepare anyone who does an education fellowship to be more like a med school dean or some like things like that, kind of more further along in their career.
So for you, Dr. Surles, are you also in a master's program? I noticed that sometimes that's something that people get involved in also when they're in your fellowship.
Sure. So some of the education fellowships are just a 1-year fellowship, but there are also a few that are a 2-year optional that gets a master's additionally. Mine, as I said, I'm a 2nd-year fellow, so mine's the 2-year fellowship, and I'm getting a master's currently in medical education from Johns Hopkins. And so by the time I'm done with my fellowship, I'll graduate additionally with the master's in education.
And you mentioned leadership roles. So is this something, if you're interested in becoming a program director or clerkship director, do you have to do a medical education fellowship in order to really be considered for those jobs?
You don't have to. It is just very helpful. Currently, the residency director at SUNY Downstate is Dr. Willis. He has no such training, essentially, from a master's. He just has a dedication and a love for teaching. That's kind of how he got his job there. However, basically, what the master's is preparing me to do is all the things that he might have had to learn on the job, maybe after it was already a problem, or he had to kind of fix it, whereas I'm being trained beforehand, so that basically once I'm done with my fellowship, I will be ideally situated to become a program director or further.
And for everyone here, did you know going into medical school or residency that you wanted to do this fellowship, or did you decide later on? Anyone can answer.
I can start. So I was a little older going into residency, so I chose to go to a 3-year residency for that purpose. I think in emergency medicine, the 3 to 4 is always a question that kind of comes up. I knew I wanted to be an educator and be faculty and work with residents. I kind of knew that going in. So for me, I always leaned towards the 3-year program with a fellowship after to give me the same amount of time, but a little bit of time doing the thing that I wanted to be interested in. I didn't know what fellowship I wanted to do till I was a mid-year PGY3, which is a little late. I suggest figuring out a little sooner would be helpful, but it worked out for me.
And Dr. Halperin?
I think I definitely sort of fell into ultrasound as a resident. A couple cool cases, became real passionate about it. Along with a few co-residents, we sort of started teaching each other, and then it just became sort of the obvious next step. It's basically how it happened for me.
Dr. Mohan, one thing I found interesting is on the EMRA fellowship guide, they talked about how some of them didn't even know toxicology was a fellowship. So I think, we'd love to know how you decided on it. Did you know going into residency if that's something you wanted?
Right. I'm a little bit biased and have a weird story because NYU has a tox fellowship and there are not that many tox fellowships to begin with. So I had a lot of exposure to my faculty when I was early on. But I think a common thread, and I'll kind of leave it up to the rest of the panel because I'm probably the most junior out of everyone here, is that, you kind of do emergency medicine and kind of like what Dr. Halperin was alluding to, you kind of just accidentally come across an interesting case or an interesting modality. And then, maybe like halfway or 3/4 through your residency, you kind of decide, can I see myself just practicing clinically for the rest of my career? Does that satisfy my intellectual curiosity, or do I need something more? I could tell you personally that when I was I went to a 4-year program, and at the beginning / like halfway through my 3rd year, I was like, I love medicine. I love practicing clinically, but intellectually, I wasn't stimulated the way I wanted to be. And tox kind of filled that role. And I think fellowship kind of satisfies that extra itch that we all have. And I'll kind of let the rest of the panelists, further elaborate on that.
So when I was at the Wilderness Medicine Conference and Dr. Mann gave the space medicine lecture, at the end of it, it's pretty gnarly what happens to your body in space. So at the end of it, I raised my hand and asked, would you go to space knowing all of this? And he actually answered, you can say what your answer was.
Oh, I don't know the words I use, but absolutely. Yeah, without a doubt, if I could get up there, I would. Unfortunately, NASA isn't going to let me up anytime soon. But yeah, I think, and that's one of the things you have to look at into a fellowship in general as well. So not just wilderness medicine or any other fellowship in particular, but can you envision yourself really sinking your teeth into that field for the rest of your life and finding a way to make that your home within medicine? So if you're interested in, pursuing really wild, crazy things outdoors, maybe wilderness medicine, if you really love teaching people at the bedside and providing education and working through their difficulties, education is a great way to go. So it's true for every single specialty. And I think that a lot of people will find that they kind of move themselves into their own field as they explore themselves through residency.
In terms of, I know Dr. Surles and Dr. Mohan, you guys both went to fellowship programs that are also at your own residency or where you did residency. So how did that work? I know Dr. Surles, you mentioned you interviewed at a couple places, but I think a lot of students have the question of, should I choose my residency based on the fact that I want to go into fellowship? Like, should I be pursuing programs that have an affiliate fellowship with them?
So honestly, I guess the best advice I can give about that is go where you're happy, essentially. This residency is either 3 or 4 years, and then fellowship is additional 1 to 2 years after it. So if you go somewhere for 6 years potentially that you are unhappy, then it's going to be 6 years of awful life, essentially. I guess the better answer is no. It's very easy to go to a residency and then go to a different place for a fellowship. I think Dr. Halperin and Dr. Mann both said they did that as well, and then now have a third location that is their actual job. It is very easy to do that. Basically, you just kind of have to make sure that you align with the program, right? Every program is going to have its own individual character, its own individual culture. And so even if you think that it has the best tox program ever, or the best whatever program ever, if you don't get along with the people there, if the culture there doesn't fit you, then maybe even great training might be difficult for you, just because you'll have to fight against the culture as well. So honestly, the best advice I can give is go where it makes you happy. Some of you are probably married, some of you have children or not. This is obviously a multifactorial decision to make, but I would not say no. I would say no. Do not pick a residency just because you know that's where you want to do fellowship.
And to piggyback off that point, oftentimes the potential for academic growth is specifically where there is no fellowship. So that's kind of what happened to me, went away for fellowship and came back and to sort of build something to sort of have that creative freedom. So there can be some real benefit in a sort of a vacuum of fellowships as well.
And Dr. Cardell had touched upon this, but whether or not you're at a 3 or 4 year fellowship, does that make much of a difference when you're applying for, 3 or 4 year residency, does that make much of a difference when you're applying for fellowship?
I might say something about that. So I think in general, probably not a ton, but there are some places where if you're expected to work academically with residents or overseeing residents as a fellow, if you're going to a 4-year residency place and you've come from a 3-year residency where you've only done 3 years, sometimes they won't let you supervise other residents because you're essentially a PGY for your first year fellowship. That would probably be the only caveat, I think. Other than that, I think every residency will prepare you well, especially if you do your own due diligence and put in the work and do good work in residency. But that would be the only caveat, I think, to that from my perspective.
Just to add on, there was this, didn't happen to myself, but one of the fellows came to my program from a 3-year program. So she obviously was in her PGY 4 year. Basically, as Downstate is a 4-year program as well. So it just kind of, the way they made it work out was that she couldn't, or none of the PGY 4s could present to her as an attending, but all other years could. So it's not impossible. If you have a place in the fellowship you go to is from a 4-year program and you are from a 3-year program, it's not impossible. They will make kind of, they will be able to kind of work around that for you. So don't make that be a barrier if that's something that you really want.
So I'm at a 4-year residency, and we do have a 3rd-year grad in our first class of fellows. So this specific situation is something we sort of dance with. I won't say dance around. On the one hand, we try, and so we have a 4th-year resident pre-attending role. So we basically say when that 4th year is working, the 3rd-year graduate fellow who's now the same sort of training age as that 4th year, he or she will be on the other side of the ER, is the setup then in reality, it's often a sort of a personality thing. And I'll go up to the 4th year resident and be like, hey, you don't seem like the type of person who would feel threatened by being supervised by someone of your same training level. Is it cool that you work with so-and-so 2 weeks from now? And overwhelmingly the answer is, of course, no problem. So it's just sort of a question of humility, I think, where most people are pretty cool with it.
And regarding that, I know that some fellowships will allow you to moonlight, which is another way to make money. So for students who don't know, moonlighting is when you take on shifts. I've never done it, obviously, but if anyone wants to speak to it, it's when you take on shifts outside of your normal schedule to make extra money. Some residency programs allow it depending on where you are, but it sounds like it's more common to do that in fellowship. If you guys could speak about that.
Yeah, so I think the big distinction, at least financially, is what type of fellowship you're going into, whether it's ACA-GME or not. So if your fellowship is ACA-GME, after residency, you just graduate to the next PGY level. So I just graduated last year from a 4-year program. So financially, I'm making a PGY 5 salary, which is not an attending salary. I'll let the others talk because I know ultrasound not yet is ACA-GME, and I know at least at my home institution, they get paid half attending salary, which is more than generally PGY 5 or 6. But from a moonlighting standpoint, I think a lot of us do it. It's all just conducive to your schedule. My baseline clinical requirement is only about 1 to 2 shifts a week. And if I have more time, I could always pick up more shifts and get paid like an attending. But, your baseline pay ultimately kind of hinges on whether you go to an ACA-GME fellowship or not.
Yep, for simulation, they're going through the process of like nationally, we don't want to be go the way ultrasound is going and be ACA-GME or do a match. It's too diverse of a specialty. So most places you will do some sort of hybrid where you're going to work clinically for somewhere around, it ends up a full-time attending is 36 hours a week at our shop. So as a fellow, you do 18 hours clinically a week. And then the rest of your time is built out around whatever is going on in the simulation department for us. And that's fairly common across the tri-state area, is it's half time and then you get paid half an attending salary. I make the same amount as a fellow moonlighting in the department. So the department has a rate they pay attendings for extra hours. And so you can make plenty of money in your own shop, just not really moonlighting, but just picking up extra shifts when they're available. It's one way to do it. Or you can do, the urgent care down the street that also pays you cash at the same rate as an attending. There's many different ways to make extra money as a fellow because you have a lot of time.
I will add that if you end up doing a program like I did that has an optional master's associated with it, most commonly what happens is that you work half time. Once again, if this is not ACA-GME, you end up working half time as attending, so you get half time attending salary. And then depending on the contract that you do, you might actually work another 1 or 2 shifts. But what that will do is that will say that the department will then pay for your master's. So that is very common. My program is kind of the only unusual one of all the places that I interviewed. This was the only one that did it this way. So I actually work more. I actually work as a 3/4 attending. So I work more shifts than just half line. But as opposed to that last quarter, as opposed to that being the department pays for my master's, that last quarter goes to me directly, and then I pay for my own master's. Like I said, it kind of just depends on your contract, on whatever you're able to work on. The standard is basically you work half time, maybe an extra shift, and they'll pay for your master's. But if you're able to work it out that you say I'll work 3/4 and do whatever, then that's up to you and the department.
And Dr. Mann, you mentioned you're involved in other things. Can you explain that? And also if it does increase your salary?
Yeah, sure. So like I mentioned earlier, there's a whole breadth of ways to try and expand your career within wilderness medicine. And personally, in fact, the reason I'm sitting in front of these maps right now is because I just stepped out of a search and rescue meeting that we had tonight to join this. So that is the big sort of outside of the hospital thing that I do right now, both dive rescue and swiftwater rescue and high angle rescue, right up in the mountains of North Carolina and and northern South Carolina. But in addition to that, I do a lot of education work, both wilderness medicine and non-wilderness medicine stuff. So I do with residents and with med students, we have a course for both of them every year. And we do local community talks and things as well. So I do a little EpiPen thing for the community that for those who are running trips in the outdoors. I talk to some of the folks around like the different EMS agencies and some of the community organizations about snakes and bears and sort of the normal wildlife that we have down here that people come into contact with. But you'll find a whole host of other things that people will do with their career. And some people will do just expedition medicine, or some people will do hyperbarics as sort of an on the side type of thing. So there's a litany of ways that you can be involved. And as far as whether or not it increases your salary, on average, for those who go into wilderness medicine, it probably does not increase your salary a whole lot. It probably doesn't at all, actually, period, quite frankly. In some instances it may, but usually what you're doing is spending those 1 or 2 years of fellowship to gain a niche in a field that allows you to do something you enjoy for the rest of your life, which I think probably for most of us who've gone through fellowship is by far more important to us than any sum of dollars.
When you were applying, how did you make yourself competitive? Specifically, even for all the fellowships? We could start with Dr. Halperin.
I think to make yourself competitive, it's if you have shown a interest, and that passion will come through in your interview and your CV and what people say about you. So I think it's, I think my advice to like the medical students out there would be, if you find something you like and you follow that passion, then it is going to be very obvious to that potential fellowship director, if that's the road, or even residency director. So, do what you love to do.
Someone asked if you recommend doing an ultrasound elective during their 4th year, and also how do you think the field is going to be growing over the years?
Well, I think it's a very exciting time for emergency medicine in general, but maybe specifically emergency ultrasound due to the technology. In the next couple years, it's happening already in some medical schools, but the technology is going to get into the medical schools such that, when you're handed your stethoscope as a first-year medical student, you're going to be handed a handheld ultrasound device to also go in your pocket. It may take my job away, but I think that would be cool. So that's how it's really going to change, is the technology is going to get into the medical schools. That's on a local level, but then in places whether it's where Dr. Mann's working in the mountains, the technology is portable. So everywhere that you can imagine, and the environments are many where there is no diagnostic imaging, period, you now do have a very useful tool in your pocket, whether that's the mountains or refugee camps or on a submarine, you name it. So the future is really kind of fascinating and will be fun to see.
And Dr. Cardell, one student wanted to know what the requirements would be for a simulation fellowship, and how the fellowship itself contributes to your advancement in your career. And I think I'd also be curious knowing how your fellowship overlaps with Dr. Halperin's fellowship, because I imagine yours also involves ultrasound.
It can. It actually often doesn't, interesting enough, as far as the ultrasound overlap. So as far as like ultrasound models for simulation, so we use some meat models in our shop for training people on how to do ultrasound guided IVs and various nerve blocks. While it is like technically simulation, that's something that our ultrasound team does all the time. And they don't need us to help them build meat models. We have a very fancy ultrasound trainer that we use for TE, or transesophageal echo training. And so that is in the sim lab, and we kind of, because it's in the sim lab, we use that for mannequin-based simulation training, where we do a cardiac arrest simulation where the transesophageal echo helps guide the provider's placement of their hands during cardiac arrest. And so we built that into a simulation with their ultrasound colleagues, and that was a really great way to meld our two specialties in terms of their ultrasound knowledge and our ability to build a practice scenario around it. And as far as like where you go from sim, so that kind of gives you an idea of, that's one way that you can use sim in a department for continuous education. So we're using that model to train all of our faculty on how to do transesophageal echo. So they get to practice in a sim where that really makes a clinical judgment change. It helps guide clinical decision making. And so doing that for attendings is a way to kind of keep our attending skills up. It's how we train each other and how to be better at ultrasound, by using this as kind of a continuous education model. And as far as where you go with simulation, one of the reasons I love my job is I get to teach attendings, I get to teach residents, I get to teach medical students. And it's a very powerful tool for those things. And you can use a simulation fellowship to kind of jump into an APD role and go do education with a residency, or you can use it to jump into really administrative stuff. There's a lot of administrative work that goes into patient safety and those kind of things. And simulation is a really good window into that. I've had opportunities both directions. I've ended up doing a lot of research as far as building some, airway intubation trainers. And so it really is a specialty that is very broad and also very narrow in the same way. The goal of a simulation training is to build a skill set in discussing education. And you build that discussing education really has power when you've pretended to do something that you would do clinically. When you can take the brain and get them to the same place they are in the resuscitation bay, you can capture the same learning that you have with real patients, or almost. And that's why it's so powerful. It's built on the adult learning theory that you need context to learn. So hopefully that explains a little bit of simulation and how it can go multiple different pathways.
Yeah, it's awesome that you're able to get involved like that. And what if someone goes to a program that doesn't necessarily have all these resources? How would you recommend they still get involved or still show an interest? And that question could apply to everyone, every specialty. Is there ways you could do a rotation or something?
So you can do rotations in a lot of fellowships. So we do an external rotation. If people reach out and they say, I want to do sim and I want to see what it's like, you can come for 2 weeks, you can come for a month. There are ways, especially in the tri-state area, everybody's so close. So you just go to another hospital for a little bit and use that as your elective time. You can just get involved with projects. I got involved in sim because a mentor of mine did sim and taught me about it. But if it's something you wanted to explore, there is plenty of ways through CORD or SAEM to get involved in sim wars or get involved in sono games. Those are things that residencies put teams together, and then they go to these conferences and compete, and that's fun. And you can lead that group, and that can be your intro into a field.
I just want to piggyback on this. I agree with everything Dr. Cardell is saying, but I do want to say that I think a lot of what she's saying is also more for residents. Going into preparing for your fellowship. As medical students, honestly, I don't think there's much that you can do or really need to do. If you want to do an ultrasound rotation, go for it. If you want to do a sim rotation, go for it. Only thing that would really do is kind of help to build your CV in order to apply for residency in and of itself. I'm just going to say that most of the stuff you do in medical school, unless you just do a lot of sim or a lot of ultrasound, is probably not going to be all that relevant by the time you are applying for fellowship. So we're not saying don't do rotations, any of these things. If you happen to be in a program that doesn't have a toxicology program or doesn't have a whatever program, as a medical student, it's probably not that big a deal. It's probably more of a big deal as a resident. But any of us, I'm sure that our emails are going to be out here somewhere. Please feel free to contact any of us. Sorry for talking for everyone, but there's definitely a way that we can connect with you in order to get you some experience that you might need. But once again, it's probably more important as a resident than as a medical student.
And I'll send out everyone's emails, if that's okay, to the students who signed up so that you guys can reach out if you want. And Dr. Surles, since you did mention that we are mostly all medical students, so how would you recommend we show an interest in, so say something like education, how would you show an interest as an MS3 or something like that?
So if you, or at least for education, I know that SUNY Downstate does a basically a medical education pathway. Obviously not all medical schools will do that, but there definitely will be some way for you to get involved basically with teaching the underclassmen essentially. My med school didn't really do that, but the way that I figured out that I enjoyed teaching was working at the student-run free clinic. My job as one of the directors there was basically that was teaching the first and second year med students, PA students, nursing students, etc., like how to do a clinical physical exam or how to write a note. And so kind of just doing those things and kind of showing that was my passion, was actually in teaching. That's how I helped to apply to residency, and that's kind of helped to form what I did in residency so that I could apply for fellowship. I think the more important thing is to tailor, as a medical student, to tailor your CV to apply for emergency. Any of these subspecialties within an emergency obviously show you value emergency medicine and would help you to match an emergency medicine residency. So I'm not saying don't do emergency ultrasound, don't do emergency toxicology. Those are all helpful and will kind of help to show that you are interested in emergency medicine. But as a medical student, it is better for you to tailor your application that you are more interested in emergency medicine as a whole.
And another thing students want to know about is burnout, because I think as med students, we hear about that, especially with emergency medicine. I know being on my rotations, they'll ask what I'm interested in and I say EM, and it's like surgery or another specialty, and they start, talking about things like that. So do you find that doing a fellowship and having a career in something else other than just general emergency medicine helps avoid that? If you want, we could start with Dr. Mohan.
Yeah, once again, this is probably better tailored for the actual faculty in the panel instead of me. But I will say that, while, emergency medicine fellowship is interesting, and, it's not like you do internal medicine and then go to cardiology, right? Where your pay increases exponentially and your lifestyle changes differently, right? Everyone on this panel still works as an emergency medicine faculty and attending, right? And we happen to do fellowship as well. So what that ultimately means is that, especially if you're staying in academia, you'll work, instead of your full-time clinical load of 32 to 36 hours, you work 18 hours, and the other 50% of your time you're teaching in didactics or teaching medical students or teaching residents, right? So in a way, fellowship kind of parlays your skills into a quote unquote better work-life balance. But the question of burnout is real, not just for emergency medicine, it's for everyone in medicine in general. But I could tell you, as with anything else in this world, a lot of it is mentality and maintaining a good mental health and balance. And a lot of it is just kind of driven by your aspirations.
How about you, Dr. Halperin?
I don't know how to make this not super cheesy, but I really do believe that if you're doing what you like to do professionally, it's going to decrease burnout. 10 years from now, call me back, see if that's true. But I think what they tell you on rotations in medical school, right? Try and think about those rotations that you're sort of driving or taking the train to work, and you're excited, you're ready to rock and roll. That's probably, my opinion would be that that's the best way to avoid burnout, is to, listen to yourself. Don't try not to listen what people are telling you should do. Do what you like to do. Medicine's such a cool field, and there's so many avenues to take. And if you're really listening to yourself and your mentors and doing what you truly are interested in, I mean, that could be anything. I think that's the way to avoid burnout.
How did you personally find a mentor? I think as med students, I don't know about the other students who are listening in, but some of we don't really have that much. We're with the resident more. We're not with the attendings that much. So I feel like, do you have any advice on how we talk to an attending or a residency director and show an interest? I think to us, to be honest, it's a little bit intimidating, So if you have any advice on how we'd approach that conversation.
That one for me? Oh, Eva, you're muted.
Oh, sorry. Yeah, for everyone. But yeah, you could start, Dr. Halperin.
I think I heard it best said once is that you can have a million mentors. So don't think it's got to be the chair or the director of this. It could be your buddy in the next chair, and then don't be shy. I think in general in academics, people get into academics. I'm hearing from a lot of these folks on this panel, people love to teach. People love to help. So, just go up, say hi. I think people are often receptive to good ideas. And if you approach them for guidance, that's kind of exactly probably why we all got into this. We like that kind of stuff.
Dr. Mann, for wilderness medicine, can you describe the type of personality that's involved in that? Are they usually outdoorsy?
I think it's kind of hard to go into wilderness medicine without being outdoorsy. Maybe at Mike's expense, I'll make a little ultrasound joke too. I considered ultrasound fellowship, and I realized as a resident, I had never beaten Super Mario Brothers, so I could probably not do well with electronic things. So I think that every fellowship kind of has people that gravitate to that field according to their personal interests. So I would say that most people who go into wilderness medicine fellowship are, characteristically outdoorsy. But that being said, I also want to tag on to what Mike said earlier, that you don't have to have mentors or specific experience in the field in the way that we traditionally think of it. Your mentorship may come from someone you might not expect and lead you into a field you might not anticipate. And so you might find that your friends as you go through residency are not the outdoorsy people like in my experience, but maybe you're really loving chatting it up with the EMS guys and gals that are coming in. And you start to realize, hey, I really like hanging out with these people. And maybe, the local rescue chief is your friend and your pal, and they can be a mentor to you. You might find that you find yourself tied into that. It could be a family member, other residents, all sorts of people can be your mentors and lead you into these different fields. So find a place, like other people have said, where you feel like you're happy and you're at home, where you're with people that think and act like you and are interested in things that you're interested in. And just, like I think probably most of us on this panel, you'll find yourself in a place that you really enjoy working.
I noticed some of you went to medical school in other parts of the country and ended up in New York or ended up in South Carolina. Like Dr. Surles, I saw that I think you went to medical school in Texas, right? So I think students would also want to know how you end up on in other parts of the country, because I think for residency, people do mention that it does help if you have some sort of connection to the area. Like in fact, I've heard when it comes to Texas, they say Texas loves Texans, I don't know if they would even consider me, who was born and raised in New York. So, and I think Dr. Cardell, you went to Emory, right, in Atlanta. So how were you guys able to go from there to now where you are?
I came to New York because my husband got a job here and I had to go to Manhattan. So that was a nice selling point when I was interviewing. As far as emergency medicine goes, we love to interview people from all over the country. We just want you to explain why you want to come here. We want people that want us as much as we want you. So if MIMO is the right fit for you, tell us why MIMO is the right fit for you. If you're from Kansas, great. We would love to have somebody from Kansas. Most of our people in this area tend to stay in the area because of family and things like that. But it's also very reasonable to stay in the area because of family and whatever brings you here. I think all of us we want to find people that like us as much as we like them. And that's an important part of the match process for residency, if that makes sense.
So I'm going to say that New York is kind of an unusual place. Pretty much nowhere else in the world are this number of emergency medicine residencies, this number of medical schools kind of all combined together. So I'm here. I'm choosing to stay here. I love it here. I'm not leaving anytime soon. But emergency medicine in New York tends to be a little bit kind of incestuous. People work here, train here, stay here, never leave here, and they train the next round of doctors who work here, live here, train here, never leave here. So kind of as Dr. Cardell said, we love interviewing people from not New York. But that shows that kind of brings in some new blood and kind of helps to differentiate what's going on. That being said, I'm going to do a little plug. Just like I said, I'm from Texas. When you're applying for residency, even though if you have family in one place and everything is in New York or wherever it is, that's fine. But don't be afraid to apply somewhere else. I do love Texas, and I do understand what you were saying. The Texas only likes Texans. It's more for medical school than for residency, but it makes sense. I can't imagine being in Texas right now. I am such a better I think physician right now because of my experience. I obviously went to medical school in Texas, so I kind of understand Texas medicine. I'm now in New York, and so now I understand New York medicine. If I did a fellowship in a third place, then I would understand medicine in a third place. And so going to new places and broadening your horizons just makes you a better physician. It makes you better able to treat people. It makes you better able to understand the social determinants of health, the social climate that's happening. Because like if I worked in Houston, where I'm from, I would primarily be seeing Hispanic patients with a minority of Caucasian. Here, my primary population is Afro-Caribbean, Haitian Creole. So the amount of diversity that I see, the amount of different pathology that I see is obviously different here than is going to be in Texas. I do plan on going back to Texas eventually because my family is all there, and just how much better of a doctor will I be with having that broadened experience profile. So don't be afraid to apply away is all I'm saying. If everyone is here and everyone's in New York, that's fine, but don't be afraid to apply to Colorado or California or whatever. You might just be surprised how much you like it.
I will piggyback and say I 100% agree. I love rural Georgian patients. They're really lovely to treat. But I also loved treating Harlem patients, and I've found a lot of learning from treating the Brooklyn Chinese population that is right next to my Mo, and the Hasidic Jewish population. And just the fact that I've gotten to treat these variety of socioeconomic status and variety of cultures has made me grow as a person. And I feel very, very thankful for that. And it's not something that I knew to value as a med student, that is just like kind of a happenstance of what happened to me, that is super valuable to me as a doctor and as a person.
For all your for your residency as well as your fellowships, anyone can answer this. I'm a DO applicant, and I know there's a lot of people on here who are DO candidates as well as IMGs. How is it for your fellowship? How friendly is it towards these type of applicants? We can start with Dr. Halperin. I know that ultrasound is one of the more competitive fellowships.
I honestly paid little attention to where you did residency. I really want to see that sort of interest and passion come through. One of the current projects that our fellowship and our residency is working on is being really spearheaded by a PGY2 who happens to be a DO grad, who I think is probably one of the most impressive people I've met in the last 5 years. So I think it's got nothing to do with the letters behind your name. It's what do you got going on.
How about for wilderness medicine? Or also, yeah, Dr. Cardell, you can answer.
Oh, I was just going to say, unfortunately, it does still matter for a lot of residencies. I think that's it's a frustration because it's hard for residencies to figure out which med school produces better med students. And so there are places that are less DO and less IMG friendly. Looking through the history of who they've accepted in the past is helpful. For fellowship, I think that all goes away. We don't care where they come from. We care that they graduated residency and that they meet the requirements to be an attending at our shop, and then that we like them. And they have to have an interest in what we do. That helps.
I agree 100% with what Dr. Cardell just said. And that holds true in our field as well. Nobody gives a darn what your degree is as long as you meet the requirements to do what we do. And perhaps even less so in wilderness medicine, where we deal from folks that come from all over the world, and we're constantly rubbing shoulders with people with all sorts of weird letters behind their name that come from Pakistan or from Kenya or wherever else that they did their training. So we don't care. We're all one group of individual we're all one team. There we go. We're all one wilderness team. And I think that most fellowships feel that way. So.
And Dr. Cardell, so you did a 3-year program and then you decided on a 2-year fellowship. Did you consider maybe doing it later? Because I know you mentioned that you had decided a little bit later. Did you consider that at all? Or how does it work when you apply later on in your last year of residency?
It really depends on the fellowship. So for simulation, it's a non-match system. If there's an open spot for fellowship and that doesn't get filled, you can apply late if they're willing to consider it. It all depends on the economics of the department you're going to. And so for simulation, where it's a field where most of the people that are interested in it are interested for very specific reasons, there's not a lot of opportunity as a resident to do simulation. You just got to participate in it and you either thought it was cool or you didn't. And so we're not looking for people that have done a lot with it. We're looking for people that want to do something particular with it. So it's much more flexible. I chose to go straight through because I knew once I got started with the attending pay, which is, somewhere north of $250 at a lot of places, that's hard to go back to fellow pay, which is half of that. And so I knew that was going to be hard for me to figure out how to budget around. And I had the opportunity for a fellowship spot because it was in the area and I really liked the program. And so that's part of why I did it. I think waiting would have totally been fine. If you're older, you kind of want to start your career. And so getting a chance to do that right after residency when you're still learning and you still want to keep learning, I really liked, because as a fellow, you have all this mentorship built in. So as a 3-year grad coming out, you're still not quite as comfortable as a 4-year grad because you've only had 3 years doing emergency medicine. And so having that built-in mentor from a fellowship when I had a clinical conundrum was really supportive and made me feel very safe.
And another question that students had was, this is more just a general question with emergency medicine. How do you guys feel about mid-level providers being hired more like PAs and NPs? How is that going to affect the job market? Those of us who are interested in emergency medicine, I mean, it does seem like a lot of other fields are having a similar thing going on. So how is it, Dr. Halperin, how is it at Jacobi?
So our system is Jacobi and North Central Bronx. North Central Bronx is, the department is essentially run by physician assistants. Jacobi historically has been very resident run, so very few physician assistants running around. I personally find it, I never worked with physician assistants actually until I went to fellowship, and I love it. Super fun, smart, hardworking on both sides. I don't think it's gonna sort of take away emergency physicians' jobs. I think there's a lack of good people all throughout the country. So I think it's I think there's plenty of room for everyone.
How is it at downstate, Dr. Surles?
At downstate in Kings County, we have a few PAs. I think there's like 3 at Kings County and maybe 6 at downstate. They're pretty much, they work sometimes in like the large ER, but they pretty much work mainly in fast track, seeing fast track patients. They always are under a physician. And so I honestly feel kind of badly for them because they kind of are an eternal resident. They have to always be under physicians. They always have to work with someone. They're very nice. I love working with the PAs. I do essentially the same work with the PAs as I do with the residents. But obviously a resident will graduate in 3 or 4 years and the PA stays on at the same time. So honestly, I have no problem with it. Honestly, we need more PAs just because the way that our current staffing is difficult, and there's like some gaps that shouldn't be there. So we're trying to hire more PAs.
And another general question students have is, how do you do well when you're on an EM rotation? Dr. Mohan, just because you're the one who's a first-year fellow, maybe you can answer that since you're closest to that.
I think a lot of us have heard the 3 a.m. test. The emergency med, I mean, we all love emergency medicine just because of the chaotic, kind of beautiful, odd symphony that is emergency medicine, where a billion different things are happening. It's chaos, people are sick, people are not sick. And at the end of the day, right, it's kind of like, being in the same huddle, right? Like you're in the same area. You want to work with people who you could trust, who are fun to work with and are reliable, right? A lot of sub-internships, when I talk to medical students, it's not necessarily being the smartest, but it's about being diligent, being helpful, and being honest. Those are more reflective of your character than your intelligence. And at the end of the day, we want people, we could trust, and people that we know we can groom. Medical school is not to make you a fully formed doctor. That's what the residency's for. So it's about, just showing your diligence and your ethic more than anything else.
And I think a lot of students are curious about scores, especially with step 1 becoming pass fail next year. Dr. Mohan, I know I just asked you, but since you're closest, if you don't mind answering, say someone doesn't do great on step 1, maybe they do a little bit better on step 2, but they have great slows. Can they still make that cutoff? Because I know obviously these programs get a lot of applicants. How do you recommend being a good applicant if you don't necessarily have the top scores?
I mean, I think it's exactly, you kind of nailed it. Like, we value slows so much because it's a real big insight into that medical student, right? Like, you rotated in a particular department. We saw how you talked with our clerks, with our nurses, with our ancillary staff, and that in a lot of ways matters much more than a 7-8 hour test.
I will say that I can't speak for every department, but at least for ours, we don't really, it's not that we don't care about step scores, but we like our slows to us are much more important. I would much rather have someone who got a 200 on their step 1, but has fantastic slows and has people that say that are people that I know in my field that trust this person and say that they are a fantastic medical student, than someone who has 280s on steps and have nothing to show for it, and their slows are like, yeah, he's fine. So I know there are some programs that probably do it like a cutoff at 220 or whatever below they don't even look at. We do not do that. We, and others can chime in, but it makes more reading for us. But we very often find fantastic residents that are below, who have lower scores, but still turn out to be fantastic doctors.
I would agree. I sit on our residency admissions committee as well. And most of the time, the scores are not the most important thing we look at. We really want to know how they are clinically and what they're like as a human being. That being said, every place is a little bit different. We do have a minimum score. It's not that high. And really, when you get above a certain number, we don't really care anymore. Like whether you got a 240 versus a 260 versus a 280, maybe if you got the 280, you're probably on the down slope of a bell curve. There might be something wrong with you. But I think that as the scores go up, that doesn't really necessarily increase your desirability. What we want to know is what the whole person is like.
I will say the way we think about scores is if it's too low, we worry you won't pass your boards. And all we want to know is you will study enough to pass your boards, because GMU cares if our residents pass their boards. That's important to them. And so it's important to us. It's also important that our doctors are prepared enough to do that. So that's the factor. So if you can prove that you can test take and do well on standardized testing in another way, do that. That'll make up for low board scores every day for us.
And so we only have a couple more minutes left, so I figured it would be a good opportunity for each of the panelists just to wrap up and say, you know, some last words to the students. We could start with Dr. Surles.
Yeah. So once again, since these are all, everyone here is probably a medical student. This is good. First off, thank you for coming. That this shows some good forethought and planning, that you can kind of start to tailor your applications and tailor what it is you are, and kind of what we as residencies and fellowships are looking into. I think really, I guess just two things is, once again, do and go where it makes you happy. Once again, if you go somewhere that you're miserable, that's not going to be a good time. And then even whatever fellowship or whatever you end up doing, you might end up hating it and never doing it again, because it's just so connected to this place that you hate. Second thing I want to say is that you don't necessarily need a fellowship to do a lot of things. You should really only do a fellowship if you feel it is going to gain you something. As we've been saying, like, you working half-time attending, or maybe even less, like, you are putting off a full-time salary. You're putting off quite a bit of money and quite a bit of potential for yourself, because you are getting something in return. Whether that's extra ultrasound time, whether that's or any of these, even the things we didn't talk about, whether that's connections if you're doing an admin fellowship, whether that's the ability to make policy if you're doing a policy fellowship, whatever you're doing, make sure that it gains you something. Otherwise, you're kind of just putting off being a full-time attending for a few years. That doesn't really make sense. So I guess that's kind of my only two thoughts, is that first off, go where you are happy, and then pretty much any fellowship that exists, you should really only be doing it if it gains you something. Otherwise, you can do pretty much all of our fellowship things without really having a fellowship and still get by.
Thank you. And Dr. Halperin?
Yeah, I could echo what Dr. Surles was talking about, is, really just, whatever you find yourself being intellectually curious about, chase it, and that's where the fun stuff comes. There's a bazillion different avenues you can take. There are a lot of cool fellowships. There's a lot of cool fields within medicine. So yeah, just try and use your time to hone in on what gets your blood pumping, and go down that road.
Dr. Mohan?
Yeah, so I'm assuming if you guys are here, you're interested in emergency medicine, and that honestly is the most important decision you've ever made already. And I promise you that matters more than anything else. You guys have chosen a specialty that values every human in this world, and that's a very big role in the house of medicine, politically, socially, and all of us have been practicing for a few years, and we all take a lot of pride in that. But to reiterate what Dr. Surles said, right? Fellowship is almost jumping the gun. You guys need to be emergency medicine physicians first. And as anyone could tell you, 3 to 4 years of residency is difficult. But I could tell you, and a lot of my co-residents made fun of me for it, if I had the chance to do residency all over again, I would do it in a heartbeat, 100%. You get to do the most ridiculous things with your best friends for 3 to 4 years, have the best stories, and you still get paid. And I married one of my co-residents. So guys, you guys are entering a wonderful, wonderful time in your life. There's nothing to be worried about.
And Dr. Cardell?
I will reiterate that residency is awesome. I loved it. I will say that EM is a specialty. I hope from this that y'all can see that it's a very diverse specialty in terms of what you can do with it. And there's fellowships we didn't represent here. There's nobody from EMS. There's nobody from sports medicine. There are people that do fellowships in administration and want to run departments. There's a lot of ways to make emergency medicine and X. And I think to the point that the field is going through a weird phase where there's less jobs this year because of COVID and volumes are down. It is a weird phase. COVID is changing things. We don't really know how it's going to play out, but there are plenty of ways to make this a career that has longevity and that gives you some buying power by doing things like fellowship, because then you can kind of augment your clinical time with other things or doing different types of clinical time. And that's one of the things I love about the specialty.
And Dr. Mann?
Yeah, I think that y'all have heard some great advice from everybody on this panel. I think that I would reinforce the idea that really focus on being a good clinician and a very good human being and learning to care about other people and learn to take care of other people. And those base skills will serve you for any fellowship you go to. It doesn't matter if it's any of the ones you heard about here tonight or any of the other ones that you don't hear about here tonight. And to echo a little bit what Dr. Cardell said, emergency medicine is a great choice. And if you're thinking, I want to do a fellowship, I know that's something I want to do, you have the whole world as your oyster when you come through emergency medicine. You can find almost any specialty you want to. There's some way to get into, there's resuscitation, there's ECMO specialties, there's critical care. There's something for everybody through emergency medicine. So don't worry that you're not going to find something you don't want to do or that you want to do. It's out there for you through EM.
Thank you, everyone. Yeah, I saw the fellowship guide through EMRA and saw how many specialties there were. And I have to say, it's really cool to be able to see that there's so many opportunities in emergency medicine. And my goal with this panel was to expose med students to the various areas so that they could consider it in the future and just know about it. And what I'll do is when I send out an email to everyone who's attended, I'll link the EMRA fellowship guide as well as the emails for all the panelists who are here so you guys can get in touch with them. And so, yeah, thank you guys so much for being here. We really appreciate it. Thanks.
Thank you.
Thank you so much. Have a good night, everyone.
Thanks all.
Bye.